let's see. So lunch is just about ready. I'm debating about whether or not to say a couple things about about the talk that I was going to do. It can also be kind of flexed down into not things. So give us 1 second. Okay, it looks like lunch is ready. So why don't we do that? So let's come back. Okay, we need 3 minutes. Entertain the people. Huh. Okay. So guy wakes up from surgery. He's been in a car accident. Says, doctor, help. I can't feel my legs. The nurse walks in and says, oh, that's because we had to amputate your arms. Oh, come on. That's funny. That's funny. Oh, fine. Whatever. um, Still giving me dance for a little bit. So to go for a couple of these things, let me just pull up my presentation and we'll just launch into it, and then you can. Sorry. Then I'll just stop when we're. Okay. All right. Yeah. So I will just say the couple of intro things on my particular talk right now, and again we'll have lunch here in just a second. So. Medical directors. First of all, for the medical directors here, thank you very much for coming out. For the EMS providers, thank you very much for coming out. The idea behind a lot of this is to get something established. Dr. Kraft and I had talked at one meeting afterwards, like, man, we really need a chance to get everybody together that wants to get together, that can talk about stuff, everybody that's interested in, doing a good job, that kind of thing. We should have a way to kind of talk and spread information and do things like a lot of other states have. So like as you may or may not, my actual EM practice is in Ohio. I live in Kentucky. I've always lived in Kentucky, basically. But my EM practice is in Ohio. And in Ohio, there's a relatively robust medical director conference. So like that seemed like an easy thing. But also, medical directors, we get a chance to talk to each other. And in Kentucky, I never really felt like we had much of a chance to talk to each other. I think it's very lonely if you're a medical director in Kentucky, because there's just not a chance to run into other medical directors very often. And that's tough. Like when you've got a bunch of decisions that you got to make that potentially affect people's lives, there's a lot that goes into that, and you want to make sure that you're doing a good job. So part of the reason that I really wanted to do this, partly was we can offer this, opportunity out there, but also because we need to, because we need to have a way to kind of get together and discuss some of this stuff. So just as by way of introduction, if you don't know me, I currently work as a contractor for the Board of EMS as the state medical advisor. I don't speak for the board while I'm here. I speak for Walt when I go to the board. I don't speak for the board. I give you my opinion, and you can take my opinion or leave my opinion, and that's up to you. But I do that. I don't think this has any significant financial conflict of interest. Just FYI. But I am still a EMS physician and a medical director. I get to fly on a helicopter sometimes. I get to go on an ambulance when I can swing it. So I'm still there, still interested in this stuff. And honestly, I do the EM stuff because the EMS stuff just doesn't quite pay the bills, and got a family and that kind of stuff. But if I could just do EMS medical direction, I would do that. So I do come from this in a relatively pure heart, I would think. Oh, good. Lunch is ready. I don't have to continue. Let me give you just a quick introduction, and we'll finish the rest here at 1 o'clock. What's your responsibility as a medical director? And again, none of this is legal advice. None of this is board say so. But if you ask me as someone that gets asked, what's the standard of care? What's our responsibility as a medical director? Well, you could go to the statute itself, or to the regulation itself, the 801 regulation, and it lists some things that you're supposed to do. And if you, what do the kids say? Snap that QR code. Is that right? Nobody knows. Okay. You guys probably know. They're all looking at me like that. Yeah. Anyway, that will take you to the K-Beams page that has the EMS statute and regulation. You can look this up if you want. But there is a regulation that says what you're supposed to do as a medical director. And it is basically these things. that you make protocols and standing orders. You serve as liaison with the local medical community, and then you interact with other people. And that's kind of, what it spells out as. There's another section in there that has a little bit more in terms of what the sort of expectations are, and that is you are responsible for the education of everybody pretty much in the service. You're responsible for restricting or limiting patient care functions, establishing destination policies. Where does your group go to? Who do you call? When do you call a helicopter? And what hospital do you go to? As well as establishing the initial qualifications of people that work for you, which a lot of us, has anybody truly had for every new let's just say new paramedic hire that comes on, do you look at that person specifically, go in and meet them, and then say, yeah, this guy's competent to practice under me? Honestly, I don't. We have a lot of turnover. I like to know who's getting hired, but I don't really get the chance to go and say hi to every one of them. I don't think any of us probably does. But that is potentially something that we're there. And it doesn't say that you, again, have to say hi to every single person that your service hires, but you at least have to establish the qualifications to get there. And then you have to have a quality improvement program for CQI as established in this regulation. And if we don't do that, then, theoretically, we're operating outside the bounds of the regulation, and that's not really legal. So we have a lot of responsibility in a really small little regulation here. And I think sometimes, and again, I don't count myself as a good medical director. I'll just far from it, man. It's tough to get that stuff done and still maintain a medical practice. It's tough to get that stuff done and have a family and do everything else that you have to do. But I will challenge us that we are supposed to be doing this stuff not just to meet the regulation, but also to help out our EMS folks that work essentially under our licenses and the community that they serve and the patients that they take care of. So this is all, again, more stuff that goes along with it. With that said, I'm going to pause and let's come back at 1 o'clock. All right. What say we jump back at it, huh? There we go. So when we last talked, when I left you, I was just about to say, well, there's some frequently asked questions that I sort of get, because when you fill out a form on the KBEAMS websites, it says like medical direction and put that as like the subject, it gets sent to me. And then they, for some reason, trust me to answer that question. So I was going to talk about some FAQs, and some of these we can just do kind of real quick, and some of them I'll just kind of gloss over just to hit the important ones. But some stuff that Walt's gotten asked that he's had to look up the answer for to follow. And come on, clicker. There we go. This is not legal advice. I am not qualified to speak as a lawyer or really about the law other than just kind of reading it. I can probably tell you about what I perceive to be standard of care and what I would tell somebody is standard of care. So this is how I answer that question, but this is not legal advice, so don't take it that way. So like questions, what if somebody doesn't follow a protocol? Is that my problem as a medical director? If you have a protocol and it's clear that somebody has to follow it, that's probably not so much an issue with you. But you do have a responsibility in that case, and that is to remediate it. So are you going to get in trouble if your paramedic did not follow the cardiac arrest protocol and something bad happened? Probably not, as long as you take some sort of corrective action afterwards and you QI it if you know that it's there. What about, like, I've got a bad guy that works for me and he had a bad patient outcome. Is that my fault? Again, no, it's not your fault. Everybody's got their own license as a paramedic or your own certification or whatever you want to call it. But you do, if you're a medical director, you do have a responsibility as the supervising doctor for it, for that. So your responsibility is not that you did the bad thing or you did something that made somebody have a bad outcome or maybe contributed to it or something. But it does say that you have a responsibility to learn about that, to find out about it through the QA/QI process, and then remediate if need be. You didn't know that somebody was a bad paramedic, or you didn't know that somebody was a bad EMT. Is that our fault? Well, it depends on if somebody's been hiding it. But in the end, again, you kind of have a responsibility to know everybody on your service. And when you extend credentials to them, you do have a responsibility. If you just know that somebody is like, you wouldn't trust them to take care of your family, then that's probably somebody that you shouldn't have credentialed. So there is potentially some liability if you didn't know somebody was a repeat bad actor. Now, what about the drugs? The drugs. Somebody steals a bottle of fentanyl. Somebody steals a bottle of ketamine. Somebody, walks off with the drug locker or something. Is that your problem? If you're a medical director, it is your problem. You don't have tremendous responsibility, at least in terms of like you didn't walk off with it, but because you have your name on the DEA form, the DEA would say, well, you need to have a policy regarding it. So if you have a policy and it was basically followed and somebody just like skirted their way around it, and it's a policy that fits in with everybody else's policy, which is, you've got it behind 2 locked doors and everybody's signing for it day to day. That's probably, yeah, you've done what you can, but you do have a responsibility to make sure that you've done what you can to protect the drugs because they are in your name and that can come back and hurt you later. Potentially, if you're using the same DEA number, which God don't do that, it can professionally affect you otherwise. So be careful with that. And again, not legal advice, but let's look at just from the medical side, what's happened to doctors. All right, here's one. Somebody follows a protocol. Everything went great, but the patient has a bad outcome. Am I responsible for that? Probably not. If you have a reasonably written protocol, and again, all the protocols that come through K-beams, if they're approved by K-beams, they've at least been looked at by a couple of people. To the extent that we can, we say that that meets the standard of care because that's what like the whole K-beams review process is there for. It's not intended to be really an onerous thing or something that just tells a medical director, no, you can't do that, dummy, or something like that. It is there. It does give you probably some protection in that you say, yeah, the board looked at this, the medical advisor looked at it, they all voted on it, everybody said this meets standard of care. And somebody follows that protocol and then the patient has a bad outcome. Patients have bad outcomes. That can happen. Don't worry so much about that, but you do have to make sure that somebody is educated on that and that you review the protocol if need be. And if it needs changes, then maybe make changes to it. Online medical control comes up. Say online medical control gives somebody bad advice. You have no knowledge of it. They call, Bocephus County Hospital, and the doc there says, yes, give 30 milligrams of epinephrine IV. And the paramedic says, okay, and pushes 30 milligrams of IV and the patient explodes. Do you have a responsibility there? Well, as the medical director, maybe a little bit, because you have the responsibility for determining where they get online medical control from. If you're not the specific doc, you probably have a little bit less responsibility for it. But as written in the regulation, you have a responsibility to determine who gives online medical control, who you cede that authority to. If it's not going to be you, you really have to say who it is. So if you don't like the docs at, again, Bocephus County Hospital because they're all locums and you don't think they know anything, it's within your purview to say, don't call them. I'm your medical director. You get orders from me, but you got to figure out where they're going to get those orders from. So again, something to be aware of. There's probably, with all these, there's probably at least a little bit of responsibility on our end, even if we had nothing to do with this call or this patient. Say that they call you and you give them orders and then something bad happens. Well, it again depends. Would a reasonable physician, knowing what you know in your situation, give that same kind of order? And again, not legal advice, but standard of care. Would a reasonable doctor do that thing otherwise? And then the patient dies anyway? Yeah, I mean, you can file a complaint against a ham sandwich as far as that goes, and say that it was not nutritious enough. So you can't stop somebody from filing complaints with regulatory boards and that kind of stuff. But if you are acting in a way that is responsible, that you don't just like kind of halfway listen, if you have a way to document that call, especially, which very few of us actually think about, but you can record calls on an iPhone now, it appears. If you can do that for your online medical control calls and prove that, yes, I did not tell them to give 30 milligrams of epinephrine to this patient, or that you talked to this person who refused transport and you gave them all the options and you said, I really want you to go to the hospital. If you have documentation of that and you do your best, you're probably going to be okay. Now, I would just give a little pitch, and again, not financially interested in these folks. If you don't have specific director insurance, you may want to consider getting some. The contracts that I have through universities have typically had some degree of coverage with it. Sometimes it's through the institution itself. But I get specific medical director insurance. The company is called NFP. I like them because it specifically covers this stuff. And when I call and ask these questions, he says, oh, yeah, this is what you do here. This is what this means and that kind of stuff. So you do get a relationship with somebody who handles a lot of the legal kind of stuff, at least from an insurance side. So worthwhile looking into, if nothing else. Let's say the service does an interfacility transport and the patient dies. Who's ultimately responsible for that patient? You might know. The ultimate responsibility for that patient, if you're doing an interfacility transport from a hospital to hospital, is actually with the sending doc. That guy or gal is responsible for that patient getting to the other hospital safely. And so we don't think about it as transferring physicians sometimes. And I work in a community shop, I transfer patients. We often don't really think about it, but yeah, you have responsibility to make sure that patient gets there safely, and you have a responsibility for setting up an appropriate team to take that patient. You can call, the patient could be on a ventilator, and norepi and vasopressin and a bunch of other stuff. Could you call a BLS crew to take that patient? Yeah, you could. You're the sending doc. You could do that. Now, what are those guys going to be able to do? Basically nothing. They're able to do their EMT stuff. If you're, as the medical director for a service, you're responsible for making sure the service stays within their scope and does what they're supposed to do and follows their protocols. But say it brings up the question of they want to send a doc with them, or a nurse, or an RT. Who's responsible for that nurse or that RT? The figure, at least from the Kentucky side, has been recently that it's the sending doc and the hospital and whoever employs that nurse, RT, or whoever, that they're actually responsible for it. And you're just responsible for the people that you provide medical direction for. Now, if you got a contract that says also Bocephus County is going to transfer somebody, and when they put a nurse on there, they fall under your medical direction, then that may be a different story. But you just got a super sick guy. Again, could the sending doc theoretically call and say, I'm going to take this BLS squad and I'm going to put a nurse and an RT on it. Then what's your responsibility as the medical director for that service? It's for the people in your service, and not so much for the actions of the nurse, the doc, that kind of stuff. If you knew about it, I'd certainly try to talk them out of, sending a ventilated patient BLS, but who knows, right? And again, I jumped the gun on it. My hospital covers me for the insurance, right? Be sure that they do, because you don't want to get left holding the bag for it. So just be careful with the insurance stuff. If I screw up, what can K-beams do to me? This question came up a few minutes ago. K-beams, as far as medical directors go at the moment, basically says that you can be a medical director or not. But K-beams does not, say that you lose your medical license. K-beams doesn't sue you, at least not that I've ever heard or anything like that. Generally, K-beams can say you can't be a medical director, but that's about as far as it can go. Now, what can KBML do? If somebody files a complaint for something that you did as an EMS medical director to KBML, they can investigate you. They can look at every facet of it. They can interview people. They can theoretically put you on a suspended license, or take your license away, or do almost anything. Any complaint that you as a physician could be for otherwise, that's what KBML can do. Now, usually KBML's kind of left medical directors out of it, but I bring it up just to say in the last year, with the complaint process as it is, a physician medical director was referred to KBML, who investigates the thing. And again, when you start affecting your medical license in a state, that's kind of a big deal, and that's kind of a scary thing. So just be cautious that KBML, it's not that, if you're a bad medical director, oh, what's KBeams going to do? KBeams isn't going to do anything. I mean, they can tell you not to be a medical director, but what could the licensing board do on your license? A lot. And that's why I think it's important that we remember that EMS is a practice of medicine. You should approach this in the same way that you might as your regular practice. If you're a medical director for an emergency department, or if you're caring for patients, you have to remember that this is a practice of medicine. We've kind of gotten away from it, and we've kind of thought of this as like EMS is kind of its own thing and it's a side gig, but it is a practice of medicine. And we've seen that you can potentially be held responsible for stuff that happens by the medical licensing authority. So not only is it good that we remember that it's a practice of medicine, because that's better for our patients, for the community, for the providers, and for our own well-being, if you like doing this kind of stuff, but remember that it does have the same medical ramifications that comes out there otherwise. It is a practice of medicine. Otherwise, if it was just the blue star, we could make a different thing. I will just kind of hit a little bit on this. I'm going to just kind of skip the protocol updates I was going to do unless anybody really is interested in it. You can read them. They didn't get approved at the last board meeting anyway. I may just mention a couple of them, but I did want to bring up this because this is kind of the genesis for a project that we've been working on. So as Mr. Briscoe mentioned, the NHTSA, the assessment committee, essentially came to town, and they look through all of the EMS program, essentially, like what's EMS look like in Kentucky, and they do an assessment and come up with a big book full of recommendations and like statements on stuff. And so I wanted to talk about the medical director section of this, because the specific, it's like there's 13 sections, I think, or something like that, and this is one specific one. They made some recommendations, and this is what they say the board should, meaning K-Beams, should develop medical director education, investigate a benefit to regionalized approach, keep working, update statewide protocols, and they recommending that folks get on the statewide protocols or a statewide protocol. I'll talk about that in a second. We got to talk about PAs and NPs. We got to talk about the osteopaths out there. Right now, the medical director regulations just have MD kind of written in there, like the allopathic. And there are a fair number of osteopathic docs out there that are willing to be medical directors and interested, and so we need to address them as well. And then talk about who it is that can provide online medical control. They make a couple of other interesting little statements in there. That again is their sort of broad recommendations. We should do something about this. A couple of other interesting statements talking about transport decisions. And they say, well, we think that this would be best if we addressed it at a regional level. So K-Beams has some destination guidance, but we don't really know like what your particular county looks like, or what your particular group of county looks like, or where Bocephus County transports to, if they go to Bocephus County Hospital, or how feasible is that? Maybe that's in the middle of a lake and you have to take a boat to get there. Transport destination decisions are probably something that is a little more local than statewide, at least. Regarding online medical control, if you haven't noticed, there's a lot of places in Kentucky that are kind of dead. Just driving through, like coming down 71, there's about a 5-mile strip where you can't get a usable signal. And that's, I mean, Northern Kentucky to here is pretty well developed, but there is dead space in there. Not only that, but from a medical control standpoint, there's probably a lot of dead space, meaning no access to a physician that really knows anything about EMS or your service specifically. Maybe it's locums guys. Maybe it's guys that say, oh, no, I don't want to be involved in that, and they just refuse to take your call. Some places have really good, robust online medical control, but there's a lot of places that, just like cell phones, you have some dead zones. And so we need to address that. And it's probably more dead zone than it is good coverage in terms of online medical control. And then, as we mentioned, nurse practitioners and non-physician providers like PAs are not really mentioned, but many of them actually came from EMS. And so is there a way to incorporate them and use their help in EMS medical direction? And we think we've got some ideas. In the end, what we've known for a couple of years, if you look at that regulation, is that we really got to revamp the regulation. It's been that way for a long time. And yeah, let's be honest, it basically says you can be a medical director if you have an unrestricted license, and then you got to do some things. Do we really keep track of who does those things? Not real well. Do we have a whole lot of recourse to go if somebody doesn't do those things? Not really. Do our initial requirements for entry make sense? Well, unrestricted license is pretty good. But I don't know if you just have a medical license and an ACLS card and a ATLS card that really qualifies you to be a medical director when it is a specific board certified practice of medicine nowadays, as it has been for about a decade. So we need to relook at our medical director regulations. We need to do those things that we were talking about before. Reflect that EMS is its own subspecialty now. When those regulations were written, again, EMS was kind of a thing that some guys did, and some guys did a lot of it. But we need to recognize that it has become its own subspecialty of medicine with its own board certification, and it is a practice of medicine. As much as we can, we want to increase medical director involvement. We need to provide support for our medical directors. We should look at PAs and NPs, again, many of whom came from EMS to start off with, and see what help we can get from them in an appropriate way. And then honestly, we got to start looking at regionalization a bit. And sometimes everybody gets a little hackles up about that. But everybody does regionalization to at least a little bit, kind of except us. And I will tell you that I'm pretty sure that we're losing out on some of the benefits of it. So let's talk just a little bit. I want to show you some ideas. So the Medical Oversight Committee at K-Beams, and again, I don't speak for K-Beams. This is not Walt speaking for K-Beams. This is Walt just telling you what Walt sees. K-Beams Medical Oversight Committee for a couple of years, probably about, let's see, year and a half now, we've been tasked with revamping the medical director regulation, writing some stuff, getting pen to paper. What would you have in it? And then we finally got to the point where we're about ready to look at them as in terms of putting them into a draft regulation. And somebody asked, well, have we really talked to the medical directors about this? I'm like, well, the ones that are here we have, I guess. I mean, I assume they read it. And this is, again, at a meeting. But I wanted to kind of throw it out there for everybody else as well. And again, I welcome comments on it. These are just ideas. This is not a draft. This is not speaking for somebody. This is not this is not anything that is concrete. But what do you think about these ideas? Let me know as medical directors. Here we go. All right. One thing we need to do in that medical director regulation is we want to establish the medical director as a statewide certification and make it a requirement to have in order to be a medical director. Does that change a whole lot? Well, I mean, it calls it a certification. It maybe gives you a patch or something, which is kind of cool. Like, that's nice. I would like another patch. Patches are fun. But as much as anything, it does say that the medical director is a part of the EMS system. And it establishes that this is not just a contracty kind of role, something that you do like the guy that comes and, fixes the plumbing. He's part of the EMS system. And so he needs to be incorporated in that. And so there should be a certification in there. Part two of what we would propose, and this is, again, just what we've kicked around and what kind of the group has talked about. We need to institute meaningful requirements and provide resources for our medical directors. Meaningful requirements to get into the role based on what your level of education is. So again, I am a board certified EM, emergency medicine, and EMS medicine physician. I have board certification in both those things, meaning I did a fellowship. I took the test and did the stuff, have the little plaque that goes, or the certificate that goes on my wall. Cool. That's not just like, okay, it's kind of cool. It's in the same way that a cardiologist specifically deals with your heart. You can go to an internal medicine doctor, and there's a great chance that they'll be able to provide some pretty good care for your heart, but there is a specialty of medicine that specifically deals with your heart. There's a specialty of medicine that specifically deals with EMS. And so I think, and I could be wrong, but everybody I've talked to has said the same thing. We do need to reflect that. So what could our initial qualifications be? Well, let's say, yes, you have to have a restricted license. You have to not be in trouble with the board of medical licensure. Cool. Got to be a physician. And then what's our requirements right now? Either be board certified in EMS, board certified in EM, and then do a little state medical director intro course, or board certified in whatever else, ophthalmology, and then do the merit badges and take the medical direction course. The idea behind this is not to say I'm board certified in EMS, so like I'm the cool guy. The idea is that I did a whole bunch of stuff to learn a whole lot about EMS, and that should be reflected in that not everybody else has done that stuff. So can we provide some additional education to folks? Yeah, if you are board certified in EM and you want to jump into EMS, you can do that, but you should probably know, 4 hours or so learning about EMS specifically, as it is a practice of medicine, we think is probably not too much to ask. If you are an ophthalmologist and you just really want to get into EMS, and there's an ophthalmologist that's been really impactful in development of like trauma care in the United States, that's cool. But you should know something about EMS. I wouldn't open up an ophthalmology practice. Maybe you shouldn't open up an EMS practice without getting a little bit of education in it. And again, you got to work out the specifics, devil's in the details. Got it. We should also be able to provide some education for our medical directors, like a yearly update course, something like this. Let's just talk real quickly about the regulations, updates in science, something like that. A couple hours a year, and then you get that done. We should put on an Intro to Medical Direction in Kentucky course where you learn about the specific stuff, not only a little bit about like take what you've learned from an emergency medicine side, but then expand it out. And how do you do that? How do you expand that into the EMS sphere? You should probably know a little bit about that before you become a medical director. And if, again, you have not been exposed to EMS at all because you've been an ophthalmologist or whatever it is, then yeah, you probably should take a little bit more training on it. And that can be the NAMSP course. There's some other courses that NAMSP makes available to you. But yeah, you should have some education, formal education, or at least semi-formal education in EMS. I think the people I've talked to think before we just say, yeah, you're good to go supervise the CMS group. Got to wrap it up here kind of quick. Part 3 would be we need to require ongoing involvement. Cool, you can get the initial certification, but then are you sticking with it? And yes, your service can fire you, but that's kind of a pain in the butt. Then you got to find another medical director. So do we have a responsibility to make sure that folks remain involved in EMS and that you remain current? I think you probably do. How can you do that? Well, we can just recertify everybody. That's an easy thing. And then we put in here there should probably be a continuing education requirement. What would that be? Say 12 hours continuing ed every 2 years or so. And you may say, well, that's a lot of time. Then here's what I would say. The education that you provide for other people counts as your education too. So what 12 hours of EMS continuing ed every 2 years would look like would be to do the 2-hour update each year, and then to provide 4 hours of con ed for your service over the course of a year. If you're going out to the service at all, you can provide 2 hours of of continuing education in a year. And we're not asking you to do it every month. I'm not saying do it every week. I'm saying twice a year, get out to the service and teach for 2 hours. And then you fulfill that requirement. Is it as much as I think we probably need from a good medical direction? Nah, it's not as much as I think we need, but it's a start. It gets us there, and it's way more than we got right now. And it at least shows that the medical director goes to the service and at least makes a little bit of FaceTime with the folks that are there so that you kind of know who the guy is or gal is. Don't mean to exclude anybody. Quickly, we should address NPs and PAs. You'll notice that the proposal so far has said you have to have an unlicensed physician in the state of Kentucky, but NPs and PAs can be helpful for it. However, the way that we can, I think, do that safely, because it's not necessarily something that every NP or PA, even the ones working in an emergency department, are going to be able to do, you can develop associate medical directors that can work for a service in basically the same delegated role as the medical director does. You would have the same continuing education requirements. The protocols, the orders, the ultimate responsibility would still rest with the physician medical director, but that would allow you to be involved. And what this would really let you do is clarify who can give an online medical control order to an EMS crew. And that is, if you say, you've got your county's EMS service, your county's hospital, and you've got a PA that works in the emergency department, if they are your associate medical director, they could, under this paradigm, give an online medical control order for that service. Now, if it's my service that's coming into the county or something like that, to drop somebody off at the hospital, I don't know that PA. He's not my associate medical director, and I'm not entirely clear. I don't really want, I don't want my crew getting a order from somebody that's not a physician. that's a reasonable thing to say. But it at least lets folks that are interested in their local EMS service get involved, and gives them an actual legitimate way to give appropriate orders with the appropriate oversight and appropriate collaboration with a physician. And then the probably biggest thing that folks have, again, kind of get a little ooh about, but I think is really important and probably the most important part of this whole thing outside of the day-to-day stuff with medical directors. We need to look at regionalization. And I think the easiest way to start that, the best way to start that, the most likely thing that would potentially succeed is if we established something along the lines of a regional medical director council. Or in Ohio, they call it a regional physician advisory board. In Virginia, I can't remember, they have the same thing, but I can't remember what they call it. What would this be? This would be a group of medical directors for, geographically contiguous area that you would get together on. And you can talk about those regional transport decisions. You can talk about regional protocols, purchase agreements, so that every service is not buying different things from Boundtree and maybe negotiate down the price. You can have regional online medical control. It's hard to do online medical control. If you don't have a regional resource for that, you are kind of, again, you're going to run into a bunch of dead areas. And then also dissemination of information. We could even look at it in terms of who writes protocols and how you write your protocols. And maybe, there's a Northern Kentucky protocol and there's a Central Kentucky protocol and there's an Eastern Kentucky protocol and a Western Kentucky protocol or something like that. And you can come up with your own regional protocol that is not just one medical director sitting there like I do and kind of like, well, I guess this works. You've got some help with it. You've got some people to legitimately talk to about it. Again, devil's in the details about how this would all actually get written. But these are the ideas that I wanted to kind of share with you. And theoretically, hope that nobody throws anything at me. But interested in comments is what I would say. And we don't have a whole lot of time for comments, but I will be happy to take what I can. Yes, sir.